Welcome back to Voices from Healthcare. Every other week, I seek to paint healthcare in vivid color as I learn more about the human side of medicine. In this episode of Voices from Healthcare.
So yes, it's definitely different when you are the sole responsible one for what happens in the surgery. So even in fellowship, technically you are an orthopedic surgeon. You could practice on your own, but you're still under the tutelage of your fellowship director and your attending. So once you're on your own, it probably took me 2 years before I wasn't nervous to some extent before going into a surgery. And that kind of gets better month to month as you go on. But even surgeries that you have not done in a while, and it's a heightened level of responsibility, right? So it's a nervousness that produces just a more intense thought process, and to make sure that you're doing the right thing. So part of it is, as I started out doing hip or knee replacement, those surgeries would take me 30 minutes longer than they do now, because I'm just much more comfortable with it now, and my own skill level and my own efficiency. So, but it's definitely a different feeling, and it's definitely a big gut check when it's all on you, because there's nobody to bail you, right?
Right.
And there's nobody to help you, so it's all on you. So
today we have a very special guest on the podcast. Dr. Davis is an orthopedic surgeon who completed his Doctor of Medicine degree from the University of Cincinnati College of Medicine. He went on to complete his orthopedic surgery residency at Mount Carmel Health System in Columbus, Ohio. He completed his adult reconstruction fellowship at the Southern Joint Replacement Institute in Nashville, Tennessee. Dr. Davis specializes in orthopedic surgery and currently works at the Atrium Medical Center in Middletown. He has served as a mentor and friend. He is respected by his fellow peers and trusted by many. Welcome to the podcast, Dr. Davis.
thank you, Jonathan. Glad to be here.
So I want to start off with home life and beginnings. Could you just describe for us your home growing up?
Sure. So I grew up here in Ohio, actually in Middletown. I had 2 older sisters. My mother was a nurse. My father worked through the state patrol as a driver's license examiner. Grew up in a Christian home as well, so a very faith-based home. And yeah, that's kind of where I started.
And so you talked about how your mother was a nurse. Did that inspire you or begin your love for the practice of medicine?
Sure. I remember going into her office as a kid and seeing the family practice docs and kind of hanging out there as well. So I think that initially piqued my interest in medicine.
And whose practice has inspired you within the world of orthopedics specifically? Was there a key mentor or someone who influenced that journey for you?
I would say not initially, so I didn't really decide on orthopedics until I got into probably halfway through medical school. So no one specifically inspired that right off the bat.
And how did you generally fall in love with the practice of medicine? Or you knew that was the direction you wanted to start pursuing?
I would say that probably started in high school. I actually read some books from a pediatric neurosurgeon. Actually, Dr. Ben Carson, during high school, and it kind of piqued my interest in surgery in general. I thought I wanted to be a neurosurgeon, and then realized that's probably not best for me. But that was probably the initial kind of peak that started that. And then I really loved just the pairing of the sciences with the ability to kind of just help people on a very personal basis. So.
And what was your educational journey in that? For your undergraduate years, just as you started pursuing that, did you have a pre-med concentration, or how did you start going about that?
Sure. So my undergraduate at Ohio State was actually in molecular genetics. That was kind of my pre-med. There was no really pre-med degree per se at Ohio State. So I got smart in genetics and probably forgotten most of that by now. But that was kind of the start of that, and kind of the jump start into medical school at Cincinnati.
And we've talked before on the podcast, but when you begin that field, you go general, and then you have the opportunity in your later years to shadow, and you're on your rotations, and you get to know more of those specialties. During that time of shadowing and rotating through different departments, did you see orthopedics in that time and were like, this is a confirmation on what I want to do?
Yes. So, in general, at least when I was going through, the first 2 years were just a lot of your book learning. You had some patient interaction, but then years 3 and 4 was much more of your scheduled rotations. And kind of the biggest decision that I was taught, and kind of as you see going through, is you have to decide whether you like the medical side of things or the surgical side of things. And that's usually pretty obvious for people whether you like to be in the operating room or not. But yes, I did have a rotation in orthopedics specifically, and then even when I decided to go into that field, I even did some away rotations at other medical schools for a few months at a time to get basically additional experience in that, and also to kind of help with the next step of getting into a residency.
That's really important to discuss that and to see how that rotation phase is actually really important in deciding ultimately where you end up. You've talked before of the unique privilege of entering medicine after the work of a long line of predecessors. So there's no pressure to initially invent that field of surgery. You're stepping in after years of development, research, progression. Could you talk about how that impacts your day-to-day life within medicine?
Sure. I mean, just from an education standpoint in medical school, I mean, sometimes medical schools will try different ways to learn and things like that, but ultimately it's a lot of just memorization starting out of all the research and science that's gone on for many, many years prior to us getting there. So that initial knowledge base is well established. And then, as you get into your training as well, I mean, you're learning from someone who has been taught, they've learned from someone else. So it's that knowledge is very much passed down. And even when I went through residency and then into fellowship from a hip and knee replacement kind of subspecialty, that knowledge base that you have is basically a culmination of everyone else that you've worked with and taught, and you kind of bring that all into your practice in one. So as you go through, kind of that knowledge is basically just passed down to you, and then you implement that into your practice as well.
That's really helpful to understand that you don't have that initial pressure to invent the field, and you have to take all of that knowledge before and just implement that in the day-to-day. Have you seen that in your own time within medicine, just even from when you first started to now, just progressions within the field?
Sure. I mean, a lot of my practice right now is specifically more on the hip and knee replacement side. So even the research that's been done over the past 10 to 20 years has really made a lot of changes and even the pain management around a surgery time period. Instead of staying in the hospital for a few days, people are going home the same day of surgery from a joint replacement, hip or knee standpoint. So I mean, a lot of advances have been made in a relatively short period of time that's been driven by just good research.
When I took anatomy and physiology for the first time in college, we talked about the bones and we talked about their landscape. And when people initially think of bones, they might think of them as brittle, or they might think of them as non-living and not very active. But that fundamental framework of the human body, it's very active and it's constantly changing. Bones have their own distinctive landscape, if you will, and you should take the time to feel the bones with its divots, its smooth surfaces, rough prominences. Could you talk a little bit about, from an orthopedic surgeon perspective, just that living landscape of bones, kind of how interesting it really is?
No, I mean, that's a great point. Kind of some of the jokes are, you're just a bone surgeon, it doesn't really matter, it's not really life-saving procedures and all this stuff. But at the same time, I always say, if you didn't have bones, you'd be kind of a blob on the floor. So, I mean, your bones are the main structure in your body that keeps you erect and upright. And then obviously your muscle attachments kind of go into that and cause all the different undulations in the bone and so forth. And really just cause the body to function. So from a general quality of life standpoint, from an activity standpoint, they're just kind of vital, obviously, to our day-to-day activity and being able to live as a human.
And how exactly does that work with muscles to bones, with it attaching? Does it attach onto the divots and rough prominences, or does it actually innervate inside of the bone?
So, I mean, most attaches directly onto the bone itself in different areas. Some of your muscles actually cross joints, and that's what causes different movement across the joints themselves. But as you kind of go through your training and your anatomy and so forth, like you mentioned, you kind of see different grooves or raised areas in the bones are specific muscle attachment sites, and that's just how our bodies were made. So kind of every muscle, how it crosses a joint or attaches to a bone or attaches to a finger or however it is, has a purpose that causes a specific function of that limb.
And the layering is incredible, right? The layering of the bones. It's not just, or the layering of the muscles that one overlaps the others, or especially in the forearm, there's so many layers, superficial, intermediate, or deep layers, and it takes time, right, to know exactly those different placements and how it's like a pulley and lever system almost between bones and muscles.
Exactly. I mean, it's a very intricate interplay of the muscles and tendons and ligaments, especially in your hands and wrists, like you spoke about. And as you kind of go through your anatomy classes, you'll see that as well. So, even in myself, if I haven't done a specific surgery in a few months or a year, and you kind of go back to it, I'll even pull out my anatomy book now just to refresh myself of exactly where that layer is compared to where the nerve is, because you always want to know where the bad things are, right? You want to know where the arteries are, and you want to know where the nerves are exactly in a certain plane before you just start diving in there. So,
and what does that look like exactly when you research in preparation for a surgery and you perform the surgery? How do you stay away from those nerves and arteries? What are the techniques to avoid?
Yeah, so I mean, it's always, you start by learning in a book and you look at the pictures, right? Then you get to the cadaver. And then, this is pretty easy because you're seeing a cadaver, but there's no blood in a cadaver, right? So then you get inside the human body, and it's a whole other ballgame. So nothing looks exactly the same, but it's having the mental picture in your mind of what should be where, and then dissecting it and finding where that is. So, you always have to know where the vital structures are to stay away from those. And once you know where the vital structures are, then you have more freedom as a surgeon to kind of know what to do from that standpoint. If you just go in there without that knowledge, then your efficiency and also your own nervousness is quite heightened. So you have to know, so that anatomy you're learning in medical school or even before that really sticks with you, and you have to know that moving forward.
Now, when we are first learning about the muscles and the bones and nerves, innervation, vasculature, we see these nice, beautiful diagrams with all of these different colors, and we see it nicely labeled and everything, but then obviously during surgery it is not at all like that. Is a main way to tell the difference based on structure between, say, nerves and arteries or veins, or how does that exactly work?
Yes, that's a great question. So thank God for people like Netter, who did his Netter anatomy and all those things in such detail, which give us, and that's, how our bodies are made is a very reproducible thing, right? So very rarely do you have the anatomic variance that it's different, and that's kind of the things you learn as well as you go through. But, the knowledge of like localizing what is what, and what is a nerve compared to an artery compared to a vein, that all comes with experience, because when you do a surgery and you get in there and there's some blood overlying things and things are bleeding a little bit, you kind of have to know what is what. And there are different things from a texture standpoint, from a visualization standpoint that you'll learn, and even from a color standpoint that you'll learn that helps you know what you're looking at.
That's fascinating to have that preparation though before, so that when you're actually in the surgery, you know what's what and you're prepared for that. You talked about anatomical variance. How significant is that in preparation for surgery? I know everyone has slight anatomical difference, but
Sure.
When you're preparing for a surgery or you're looking at a patient and preparing for that, how much does that play into the prep?
It's more just knowing those variants when you go into a surgery. So I do a lot of hip replacement. So your sciatic nerve kind of runs along the posterior aspect of your hip joint. So there are certain variants in whether it goes over top or underneath your piriformis muscle. So normally, you retract your piriformis muscle, it's safe. But you should always have a heightened sense of knowing where that sciatic nerve is to protect that during the surgery, so you don't have an injury to that afterward. Same thing from like a carpal tunnel release in your hand. So there are certain variants on where your superficial nerves come out. So you have to know what those variants are so you don't accidentally hit that nerve and cut that nerve.
Wow. And so we talked about that living landscape of bones and how it's very active. There's the fascinating aspect of relocation of bone density with a weaker area of the body. Where it's weakest structurally, the bone density will kind of change based on where that body is weaker structurally. Could you talk a little bit about just that idea?
Sure. I mean, so our bones are made to remodel, so basically break themselves down and rebuild, and that's actually stimulated by walking and being active. So we see this in people who are very sedentary, and if you even look at an x-ray of their bone, you can tell that their bone quality is thinner, or just not as good of a quality as someone who is more young and active. So it's kind of one of the amazing ways that our bodies are built, and our bone is made to remodel. So same concept with fracture healing. So when you break a bone, your body's made to throw down new bone, then remodel that into a normal-looking bone over the course of a couple months to a year.
Fascinating. I know some schools offer a cadaver experience for students where they're able to take a cadaver class and they're able to get very, very good experience in their undergraduate years for hands-on experience and starting to learn muscles and innervation, vasculature, and so on. How might prospective students who are still in their undergraduate years get other hands-on experience?
So I'd say first off, if you have that opportunity in undergraduate, I think that's a great opportunity. If you know you may be going into medicine, to kind of give you a jump start in that. So I think that would be a great thing to do. I think from other opportunities to see that outside of a schooling situation, there's shadowing opportunities. You can shadow surgeons and things like that to kind of get some understanding of that as well. Do you have any other ideas on that yourself?
I have found shadowing to be extremely valuable, and you get that experience, and it's a relatively easy process, some paperwork involved, but to just be able to see that is a great perspective.
Mm-hmm.
And I think maybe students don't take enough advantage of shadowing experience, but that would be the first thing that would come to my mind, is that opportunity to see the surgeon at work and to be able to see what a day-to-day looks like, and you almost have that ability to just see firsthand without any of that initial responsibility yet.
Exactly.
So you can kind of take a step back, but you still have a lot to be able to see and observe and take in, and you can see then when you're shadowing kind of what sparks joy and what sparks a love kind of when you're in that area.
Yes. No, those anatomy labs have a lot of learning and a lot of fun and just amazement as you look at the human body and how it was created. So,
absolutely fascinating. I want to touch on the idea of collaboration. There's a lot of collaboration within the medical field between all different types of professions, between doctors and nurses and anesthesiologists, and there's that importance of realizing that there's a competent team behind you, and that leads to great efficiency within the workplace. Could you talk about how you've tried to implement this in your own practice? Just that idea of realizing that team behind you and how that has led to efficiency.
Sure. Yeah, so that, kind of the term we use, kind of the multidisciplinary approach to medicine, or kind of any kind of subspecialty. So, and just to use the example of hip or knee replacement, I mean, your primary care physician is important just from a medical side of things to get the patient prepared for surgery. In the office, your athletic trainers or your medical assistants or nurses play a vital role in kind of getting that patient ready for surgery and kind of helping you out with your own efficiency in the office. And then on the day of surgery, there's a lot of interplay with that. There's the nurses that see the patient beforehand. There's the anesthesia team. There's the nurse and the scrub techs and the assistants who help you in the operating room. So your efficiency as a surgeon is based on your own skill and your own comfortability and your own speed in surgery, but it's also based on how well you work with your own staff. So if you have a skilled scrub, a scrub technician, and your skilled assistants who know what you do and know your steps, your case can go very smoothly. If there are people who are unfamiliar with what you do or you have not worked with before, it can add an easy 10 to 15 minutes to your surgery just because of the inefficiencies that come with that. So part of establishing that team is just working with the same people over and over again so they can learn you and you can learn them, and you can help each other along to get the best outcome for the patient.
And I know 10 to 15 minutes might not seem major, but if that's multiple surgeries, it's that cascading effect of over time. It just keeps adding up to the day.
Exactly. Yeah, I mean, if you have 6 surgeries in a day and every case is 10 minutes longer, you've got an hour working there. So
exactly. And that's amazing to see that you also have to realize that certain people, if they are skilled, you give that certain task up to them, and then you can be more efficient as a surgeon with delegating some of those tasks, and then everyone works together as that team. Within the world of surgery, there's a lot of subspecialties, and you specialize in that hip and knee replacement, and you have that training in the direct anterior approach as well as the posterior. Could you talk a little bit about how to pursue a subspecialty, maybe after you've completed your general training, and then as you decide you want to pursue a specialty, kind of what that looks like?
Sure. So, as you go along in training from medical school to residency, so certain residencies have additional years of training you can do. So, such as, family medicine, you can do a sports medicine fellowship for a year. Within general surgery, you can do plastic surgery or cardiothoracic surgery. So the landscape of those are kind of all changing nowadays with different residency paths. But from an orthopedic standpoint, once you get into orthopedics, you do your 5 years of orthopedic residency. And after that, you're kind of trained in a very broad range of surgeries. And then an additional year of, it's called a fellowship you can do, which basically is a additional subspecialty. So for myself, I really liked hip and knee replacement. I liked how the patients did well afterward. They regained their quality of life, and it was very rewarding as a surgeon to see your patients do well. So now in practice, I do the majority of hip and knee replacement, but I still do some of the general orthopedics, meaning the fracture care, ankle fractures, hip fractures, things like that would come through the emergency room. So you can choose to kind of do whatever path you would like to do, whether that's more of a general side of things or a more subspecialty side.
And within hip replacement with anterior and posterior approach, is there one that gives a much quicker recovery time to patients?
Sure. That's a great question. I get that a lot from our patients. So there's, as always, a lot of marketing around a lot of these things. The direct anterior approach had a lot of marketing recently. It's not anything new. It's been around for a while. But, in general, it's more just the difference in where your dissection is and where your muscle planes you're going to get down to the hip joint. And there's differences in your recovery and what we call hip precautions afterward, meaning specific positions we don't want your hip in until the body kind of naturally forms scar tissue around that hip. So in general, what I tell people from a direct anterior approach, kind of on the front of your thigh, your recovery is about 2 weeks quicker because you don't have to go through your big gluteus maximus muscle, and typically they're a little less sore. But by about 6 weeks out after surgery, regardless of the approach that you do, the results are the same. So long-term results are the same, short-term results a little better with the direct anterior.
Got it. And we've talked about it before, but you've really fought hard to have that streamlined as much as possible for having same-day surgery for patients, or not, once they have a surgery, not having them be in the hospital for a while afterwards. Could you talk about why that is so important to have more same-day surgeries when possible for patients?
Sure. I mean, just in general, as I talk to patients, it gets them back home basically to their own environment, their own bed, their own food, their own family support, right? So even when I started at my current hospital 5 years ago, people were still staying in the hospital at least a couple nights after a joint replacement. There's been a lot of good literature over the past probably 10 or 15 years looking at kind of the safety profiles of people going home compared to staying in the hospital, and it's shown no difference. So the kind of big push over the past few years, especially, is to get patients home the same day. So typically you'll have a surgery. Once all your anesthesia wears off, you'll get up with a physical therapist, and you'll walk around using your walker. As long as you're doing okay, we'll get you back home. So, I would say that probably 95% of my patients now are able to go home the same day of surgery after an elective joint replacement. So, and people have been happy with that. So it's been very positive.
And then do they come back after a certain amount of time to check in and touch base with you to see how their recovery is going?
Yes, so I see them at 2 weeks after surgery and then at 6 weeks after surgery. And as long as they're doing okay then, typically we just talk about kind of getting back to life and activity. And then I'll routinely see them at kind of their 1 year follow-up just to check in on them once again.
Got it. And you have seen that difference between first coming, how patients would stay maybe a couple days, and then having them be more that same-day surgery?
Yes, and the biggest way we've been able to do that more is just from a nerve block standpoint and a pain control standpoint after the surgery. So it kind of starts before the surgery, during the surgery with the anesthesia group, and then also with some of the injectable blocks that I use around the hip or knee joint. And it really allows them to get up and move, and your pain is actually better in the first kind of 24 to 36 hours after the surgery than it is even a couple of days following that. So it really allows you to get back home.
It's really important to have them be in their home environment, in their natural environment as soon as possible, and how that can aid recovery. I want to touch on bedside manner a little bit. I know it's really, really important to stimulate that physician-patient relationship, and that's really important to put them in a good frame of mind for surgery, and then also before surgery, just to have that trust in you as a surgeon.
Yes.
Could you talk about how you've tried to implement that in your practice, that bedside manner?
Sure. So, I mean, just on a more humorous note, I mean, in general, my patient population is kind of over the age of 55 to 60. So I get the comments all the time of, man, you look young when I walk in the room. So yeah, establishing that rapport is important. And you know, how I was kind of taught in medical school is you sit down in kind of a relaxed position and you just kind of look at them in the eye and you just ask them what brings them in today, and you kind of let them talk instead of just pounding them with questions. And a lot of your history and so forth, as you'll learn, you'll get just with allowing them to talk and so forth. You know, nowadays we're tempted to get on the computer and just start typing away with your back to the patient, and it really is just not good to build a relationship with people. Everybody likes to see the patient, see the person face to face. And, you know, from a patient standpoint, you know, the patient has to trust you as the surgeon that you're going to take care of them and that you have their best interest in mind. So I never want to do a surgery on someone who does not trust me or trust that I will do my absolute best for them. There's a lot of things that go into that, but just having a face-to-face conversation with them, allowing them to ask questions, and not feeling rushed. Nobody wants to have a surgeon that runs in the room and then runs right back out of the room and they don't know them. Time is always of the essence, and you can't spend an hour with every patient, but definitely on a patient I'm signing up for surgery, I'll typically spend 15 to 20 minutes just to make sure I answer their questions and that they know what's going to be coming forward. So.
And how do you ensure that they're in a good frame of mind right before the surgery? I know sometimes the lead anesthesiologist comes to get them and brings them back to the OR, but is there anything that you have realized that's been effective like right before surgery when they might start to panic or be like, wow, I'm actually going into surgery now? Is there?
Yeah, I mean, that's a good question. There's always, you're always kind of surprised at who handles things well and who does not handle things well. So, you know, in general, you know, when I go in them, I see all my patients prior to a surgery. And I just ask them if they have any questions. You can kind of get a good sense of how they're feeling then, and then their family members are with them too. And the other thing I've started to do over the past few years is just offer to pray with patients before a surgery. So I just leave it very generic and entirely leave it up to them. But if they're okay with that, then I will offer to pray for them and just for the team and just for the success of the surgery. And I found it, in general, it's been a very positive response. And people have, it actually helps to calm most people down just to know that your surgeon, whether you have that same faith as your surgeon or not, but just to know that he has a faith as well going into that surgery, and it kind of builds that relationship like you talked about, so they can trust you.
I want to take a look into the surgery room. Everyone has a first day, and there's that stage when you're in medical school and then you have that constant mentorship and you're side by side and you're constantly learning. But there's that distinctive moment when you're doing your first surgery and you do not have that mentor standing right next to you. It's your first surgery alone as the lead surgeon. Could you take us into like your first surgery without your mentor, like right there, like
Sure.
when you're...
So I'll take you all the way back to a first funny moment of being in the OR first, and then we'll jump to that. So, you know, as a med student, you're taught all the sterile technique, how to scrub and all this stuff, and it's really about, it becomes second nature to you, right? But, you know, you can't go to the floor for something, you can't touch things, you can't do all these things you're like thinking about as a med student. And I was in one of my first surgeries and something dropped on the floor and I was thinking, I'm going to be a helper. Let me go pick that up. So I'm scrubbed in and I literally try to go reach down to the floor to grab something. And the scrub is like, get out of here. Like, you got to walk away. I was like, what? And then you realize, oh, wow, I really can't do that. So, you know, you're not sterile anymore. You got to scrub out. So just an embarrassing moment, but, you know, it stuck with you. So fast forward that. So yes, it's definitely different when you are the sole responsible one for what happens in the surgery. So even in fellowship, technically you are an orthopedic surgeon. You could practice on your own, but you're still under the tutelage of your fellowship director and your attending. So once you're on your own, I mean, it probably took me 2 years before I wasn't like nervous to some extent before going into a surgery. And that kind of gets better month to month as you go on. But even surgeries that you have not done in a while, and it's a heightened level of responsibility, right? So it's a nervousness that produces just a more intense thought process, and to make sure that you're doing the right thing. So part of it is, as I started out doing hip or knee replacement, those surgeries would take me 30 minutes longer than they do now, because I'm just much more comfortable with it now, and my own skill level and my own efficiency. So, but it's definitely a different feeling, and it's definitely a big gut check when it's all on you, because I mean, there's nobody to bail you, right?
Right.
And there's nobody to help you, so it's all on you. So,
but it is really important to have all of those formative years beforehand with that mentorship, and then you do feel ready.
Definitely.
Even if you are nervous or whatever.
Yeah, and I mean, I felt that I had great training coming into from residency and from fellowship, so I felt fully confident in my own skill going into that. But it's still that extra measure of, oh wow, it's all on me now. So
right.
It's good. It's good, and it keeps your mind in the right spot, that it's important and it's vital of what you're doing.
Orthopedics is far more surgically physical or fast-paced than anyone might think. It's very fast-paced, it's very engaging. I know in our conversations you've referred to it before as human carpentry. You literally have your surgical drills, and you're fixing what may be a fracture, or you're replacing a knee or something like that. Do you have any favorite surgical instruments or anything that you have enjoyed working with?
Yeah. I mean, in general, patients don't like to hear that, but yes, it is like human carpentry, essentially. Some people who are actually carpenters actually kind of latch on to that and say, oh, that kind of makes sense. So, sometimes when I'm talking to patients, they'll talk about, the rod you put up my femur, or the shank you put there. And so, I mean, they'll use different terms that kind of just, in their mind, kind of relate to what you're doing. But, I tend to like the bigger the better. So, some of the drill bits that I'm using on some of my hip or knee revisions, I mean, they can be up to 2 centimeter in diameter drill bits that you're using. And some of the implants are the same size. I mean, you have quite big metal objects that you're putting into the patient's bodies. So I find that very fascinating and very enjoyable.
And it's fascinating to see when you look at an orthopedic surgery and you see that surgical field and you see all of those tools listed out. There's so many, and there's even that type of blender to mix that type of cement that you use.
Yes.
To put those placements on for reconstructions and replacements, and it's absolutely fascinating.
Yeah, I kind of, and typically on a knee replacement, I'm cementing those knee replacements. So as I describe it to the patient, I kind of describe it as grout. I put grout in my bathroom, or something else like that. So they kind of get an idea of, I'm cementing this onto your bone. So that's part of the patient relationship, right? So I mean, you're kind of using terms that they would understand more than just the medical terminology that you use on a day-to-day basis.
And how long does it typically take for that cement to catch and to harden?
So most of the cement, it's 12 to 14 minutes. But by the time you start mixing it, so it's a powder plus a liquid, then you mix that together, and you've got about a 12 to 14 minute window before that hardens. And then, it fully solidifies within like the first day, but right after that hardens, it basically heats up. And you're good to go. So the patient can get up and walk on it right away.
Wow. How do you constantly stay up to date with new treatments or procedures within the world of orthopedics, as it's constantly changing and new developments are always being made? How do you stay up to date?
So I mean, a lot of it is subscriptions to journals. So the Journal of Arthroplasty is one that I kind of keep regularly and kind of keep up on. You get stuff through your CMEs that you're required to do, but then there's also conferences that they have multiple times a year. And really, things change quite a bit. Realistically, it takes about 4 to 5 years for me to really be different, maybe. So as long as you're going to conferences every few years to kind of keep things refreshed, you'll kind of get an idea of what's new.
Now, within the surgical team for orthopedics, usually you have a designated X-ray person that will come in and will X-ray what's been put into the patient during a surgery. What are you looking for in terms of alignment with those rods, or what are you trying to see in those X-ray
Sure.
images?
So a broken bone obviously we call it displacement when the bones kind of pull apart. So in surgery, when you're looking at it, and we call it reducing that bone, so you reduce it back to its anatomic spot. So you use clamps or different tools to do that, and then you take an X-ray picture, so it's called fluoroscopy, intraoperative fluoroscopy, so in the operating room X-ray, to basically look and confirm that what you think with your eyeball is actually correct on, realistically would be on an X-ray. And then once you have that, then the fluoroscopy also helps you to guide the placement of the implants, whether it's a plate or screws, or whether it's a rod, like an intramedullary, so inside the femur rod. And then the other thing, it also allows you to do much more minimally invasive procedures. So a lot of times when we fix a femur, if a patient comes in with a hip fracture and we have to fix that, we can do it through a couple centimeter incisions versus opening up the entire femur. We no longer have to do that. So that really allows for more minimally invasive surgery to fix fractures.
There's also that fascinating aspect within orthopedics of sometimes using tendon to fix torn muscles. There's a technique, right, to use tendon to kind of repair that.
Yeah.
Could you talk a little bit about that?
Sure. So I guess the most obvious one probably people have heard of is like an ACL reconstruction. So a lot of those are done. You can do bone patellar bone, or you can do allograft, meaning another tissue from somebody else, or you can use like a hamstring tendon. So a lot of times the push nowadays is do kind of hamstring tendon ACL reconstructions. So yes, there are certain situations where you use kind of your own tendon or a cadaver type tendon and allograft to reconstruct things.
And there's certain trauma cases as well. If there's the idea of being on call, and you've talked before about it's nice that sometimes in orthopedics you don't have to come in when you're on call necessarily all the time, but sometimes there are trauma cases or some urgent matters that need to be attended to. Have you been involved in a trauma case or something like that?
Sure. You see a lot of that during your training, and then depending on the hospital that you work at in practice. So, emergency things that need within a couple hours care in orthopedics are typically open fractures. So bad fractures, or we call comminuted fractures, kind of in multiple pieces that tend to go out through the skin. So anytime you have a bone that sticks out of the skin, it's not a positive thing. So you treat that with antibiotics and then a surgical debridement, or kind of cleaning out that area and then fixing the bone at the same time. So those are things that typically we try to get to within a couple hours, or at least within the first 24 hours, depending on the type of break as well as the type of the open wound.
You've touched on it before, but could you talk to us about the rehab process and what that looks like after surgery? Are you working with PT or rehab specialists to develop treatment plans for patients?
Yes, so it all kind of depends on what the injury is, what the surgery is. On a replacement or a joint replacement side, the physical therapists play a vital role in that, because you're allowed to walk on it right away. You work on the motion of that joint, of that new replacement, and the physical therapists really help to get their muscle strength back quicker, and also kind of reduce some of the swelling that can occur after surgery. Certain injuries, like certain fractures or breaks in the bone that are fixed, require you to basically not put any weight on that extremity for a period of time. So it kind of is, your physical therapy and your rehab is tailored to kind of what surgery you've had.
How have you seen orthopedic surgery advance, and progressions and ways that surgery has been done, or have you seen any type of advancement in your time?
Sure. From a hip and knee replacement standpoint, different implants have come out, different advances within that, and also kind of around the pain control around the surgery time, like I touched on before. From an ankle fracture standpoint, one of the injuries you can have is called a syndesmotic injury, meaning you tear the ligament between your tibia and your fibula, or as the common term we see with athletes is a high ankle sprain. So there's been advances even in how we fix those. So we used to have to fix them with screws, and you then had to take out after a couple months. There's been new technology with what we call, it's like a tightrope or like a heavy suture that can be used. It can actually stay in, and you don't have to undergo another surgery to take it out. So there's been different advances, both on kind of a joint replacement standpoint and from a fracture and really a sports medicine standpoint. So yeah, there's always something new, technology coming out. You got to kind of figure out and siphon through what's important and what matters. But yeah, there's been a lot of stuff, even in my kind of brief time of training and practice.
And what within the world of orthopedics excites you in the next couple of years as you think forward? What is exciting to you within that field?
So, I mean, I think a lot of the up-and-coming things you hear about, stem cell technology and things like that from a kind of biologic standpoint. If somebody ever figures out how to get that stem cell to attach to a bone and grow cartilage, then I'll be out of a job as a joint replacement surgeon. So, but from a patient standpoint, that would be great technology going forward. I think things that excite me more, just because I'm a joint replacement surgeon, are just advances in that and how to basically improve patients' quality of life from the implant design, how long the implants last, and so forth. It used to be when you had a knee or hip replacement, they may only last you 5 or 10 years because certain parts would wear out really quickly. The way they process those implants nowadays, typically you're hoping for 20 to 30 years for a joint replacement to last you. So, I mean, even that reduces the amount of surgeries each individual patient has to go through, which is always what you want as the surgeon of your patient. So,
let's say you're walking in the hospital and you see maybe an undergraduate student who's shadowing, maybe isn't in the medical field but is just starting to discover what's within medicine. You get in the elevator together and you're going up a couple floors. You don't have a lot of time. You kind of have to just describe to them if they ask, what do you do? Like what is at the core of what you do? What would you say in like a succinct way of like, this is who I am and this is what I do?
So I'd say, as an orthopedic surgeon, my job is to help restore function and gain patients' quality of life back. I think it's pretty much as simple as that. I mean, typically you're seeing people who are in a need where they have a dysfunction in their body from a bone or joint standpoint that causes them pain, that causes them an inability to be active. And kind of my job as a orthopedic surgeon is to regain that function and to get them back to anything they want to do.
Could you talk about recognizing genuine friendships within the medical field between doctors and with those people that you grew up together and then had that education together? Could you talk about that value of maintaining those types of friendships within the medical field?
Sure. And I think we kind of see that in any kind of job situation you're in, but I think specifically being a physician, having friendships with people who are also physicians is important because you kind of understand, what you went through in training and kind of where you are now. Because it's like any other training, but specifically in medicine, it's a very rigorous training from a mental stress standpoint to a lack of sleep standpoint, just a lot of different aspects. So it helps to have those friendships with people who understand kind of what you've been through and you understand what they've been through as well. So when issues arise or they're struggling with something, you can kind of really help them through that. So I know for me, I had a couple really good friends in medical school that, we shared our experiences going through training, but also we shared our Christian faith. And so it really was able to kind of spur each other along during the difficult times and kind of get through that. So, and those friendships have kept going forward. And we still talk today. So
it's so important to recognize that those friendships have so much value, and like you're saying, you need someone to share that mental stress with, and those difficult aspects of medicine and your training, and to be able to talk to them and to collaborate. Even when you have pursued that education and you've achieved that role, you can still collaborate and talk to them too. So
and it's it's the career that you do, and doing surgery. Not many people really want to hear the details about what went on in the surgery. It kind of grosses them out, right? So, I go home and tell my wife and my kids something, and I tailor that differently than if I was talking to one of my friends who's also a surgeon, because you can go into much more detail and say, "Ah, it was really cool," and they can kind of understand what you're talking about. So yeah, it really helps to have that friendship.
What about advice for the prospective student? Just generally, someone who is interested in pursuing healthcare, do you have any advice that you would give them now in their undergraduate years and even further along the journey?
Sure. I mean, I think as you go into undergrad and kind of as you advance forward, every year you go through your education and training should kind of confirm what you want to do. being a physician of any subspecialty, it's a long haul. So, my post-high school education was 14 years before I had my first big boy job, okay? So it's not like you go for a year or two and then you're out doing stuff. So you really have to have the mentality of I'm in this for the long haul, and there will definitely be ups and downs to that. But the more you go along, the more confirmation in your mind that you really enjoy what you're doing. You really have to enjoy what you're doing. If you don't enjoy what you're doing, or at least enjoy what you see as the end result of what you're doing, then you should probably be switching what you're thinking. Because the enjoyment of what you do and taking care of patients really gets you through the times where it's a struggle.
And there really is that sacrifice of love in those years of education and in it for the long haul and pursuing that and having that distant goal in mind. Could you talk about how when you might have had difficult aspects in education, but just that idea of holding on to like, I know what I want to pursue eventually, and that helps me, kind of propels me through that?
Yeah, I think that medical school had its own challenges, right? It's a lot of book learning, it's a lot of rote memorization, and it's then starting to apply that into your taking all that head knowledge and then putting it to patient care, right? And that continues kind of as you go into residency. I mean, I think from a sacrifice of love standpoint, it's, if you have a family, if you have kids, I mean, the sacrifice is not just yours, it's your family and your children also seeing that as well and going along with you on that journey. So, I was married quite young, so my wife we've been together through undergraduate, through medical school, through residency, so she's seen all the good and the bad along the way, and it's really supported me in that. But, just from a workload standpoint, I mean, we had 3 children during my residency, and I don't remember a lot of their young years. You do remember kind of snippets here and there, but like for the most part, I was not around that much because you were working a lot of that time. So I knew that was a temporary stopping point, and that wasn't my whole career, so that kind of allowed me to kind of push through that time. But you really have to maintain those relationships with your own family and your spouse, if you have one, just to kind of give you support through those times.
And it's not just your goal of pursuing an end goal, but if you do have that family, you have to, think about that, and just managing all of that can be challenging at times.
Exactly. I mean, it's them. They also know that this is a temporary time period, and it's for a better end goal. Better meaning a little more control of your own lifestyle, and how you can kind of prioritize your family and your work and so forth.
What about when you first came into practice after finishing med school? Was there a big difference for you between that textbook knowledge and then, wow, I'm actually taking care of patients now? Was there a divide there, or?
Yeah, sure. I mean, that's what we kind of taught that in medical school too. Like, and you'll see kind of new interns coming on the floor for the first time. There's a bunch of jokes about that, but I mean, it's really, as a physician who's gone through that, you realize that you have all this knowledge in your head from a book knowledge and examples you've seen on tests. And then when you see it in a real person, you have to basically take all that together and summarize it and then implement it into kind of the patient care. So yes, that is definitely a challenge to do, but that's also why you have people who are a couple years ahead of you, then kind of guide you through that and kind of help you think through that. So it kind of goes back to the thing we talked about at the beginning of just you're kind of building on the experience of those who have gone before you, so that when you get a year or two ahead, then you can help the person who's coming up behind you as well. So it's a very collaborative effort.
And what about just practical advice for the aspiring medical student? I know that orthopedics, there's a lot of memorization involved with muscles and bones and nerves, vasculature. Do you have any techniques or things that you found valuable in your educational journey of just, this was effective for me?
I think that's really individualized. So you kind of have to learn on your own, kind of going through undergrad and medical school, how you study the best. Whether that's someone who does lectures better, if you can learn from that, whether it's someone who you have to study on your own for. For instance, pharmacology in medical school, I had stacks and stacks of flashcards of just drugs and all this different, and it just, you just go through them, and I kept those for a while. I mean, it's, a foot or two worth of flashcards just for pharmacology. So you'll kind of learn, depending on the topic that you're learning, kind of how you best learn through that.
It's really helpful, though, to get that advice, and never underestimate the power of the flashcards.
No,
I
it still
use
works.
them. Yeah,
It still
yeah.
works.
What about any closing thoughts for people interested in orthopedics and just people generally just starting out on that journey? Any closing thoughts?
Yeah, I mean, I think that medicine in general is a very evolving field. I think it's a very rewarding field. So you're getting and you're taking care of people at a time of need for them. So from a physical standpoint, you're helping them out as a doctor, but it's also a time where you can talk with them and kind of just get an idea of kind of where their mind is and what their thoughts are and their beliefs are, and you can really get them at a time where you can be very influential and just a good way to get them on a more healthier path going forward. I think people who are starting out in training, you got to be ready for the long haul. So I think I've talked with you about that, and I kind of just really try to gauge people I'm talking to, like how serious are you about this? So if it's like, I could be a doctor, or I could be something else. If you're kind of wavering back and forth, then you probably should go to the other route, because you may not kind of make it through all the push of the training. So you've got to really desire to do it and have the desire to do it for the right reasons. You've got to work hard, and as I kind of told people in residency who are a few years behind me, you work hard, you put your head down, and you keep pushing forward. Because sometimes that's kind of all you can do, but the end result is great, and I thoroughly enjoy what I do, and I really can't see myself doing anything else. And I think that's not many careers have that, or I should say some people have to go to a job where they really just have to go to a job to make money. I also go to a job to make money, but I also really thoroughly enjoy what I do, and that's definitely a blessing.
And there is that stage of full commitment to that process, and if you are wavering, you should really honestly
Evaluate
think and evaluate. Yeah.
And it's okay to waver back and forth a bit, but once you dive in, you got to dive in.
Go in fully. Yeah, 100%. Well, thank you so much for coming on the podcast and just talking through the world of orthopedics with us and giving us a window into your life and your role as a surgeon.
Yeah. Thank you, Jonathan.
Of course. Thank you for tuning into this episode of Voices from Healthcare. This podcast seeks to give practical advice to aspiring healthcare professionals and encourage those within the healthcare field. If you appreciate the message and mission of this podcast, leave a rating and review on the platform you are listening to, and make sure to follow the podcast so that you do not miss out on future episodes. It really does help spread the word within the podcasting world. Tune in on October 25th as I gain unique insight to the world of medical surgical nursing. We will touch on the transition from college to the professional workplace and the value of a preceptor program. We will delve into the day-to-day of hospital life, the relationship between nurses and residents, and the organization of the med-surg floor. We will consider the world of IVs, crucial issues within the world of nursing, and the difference between medical dramas and hospital realities. I will hear how she was involved in a hospital code and her hopes for the future as she continues to grow within this space. Feel free to send me professions you want me to interview, questions you have, or neat stories you want to share with me. You can email me at voicesfromhealthcare@gmail.com. You can also check out the podcast Instagram page at voicesfromhc. Here I'll post important updates about season launches, episode information, and more. Although this podcast seeks to be informative, information discussed cannot be taken in place of medical advice.